I'm gonna share again my screen and ask Pavel to introduce the webinar series as a whole. Pavel.
Okay. Hello, everybody. Today's webinar is one of a series of webinars. We have planned a total of 10 webinars, which we started a month ago. And a month ago was the first meeting, and the next ones will be held in the following months, as you can see, until the end of this year. Each webinar will last about 30 minutes, with approximately 20 minutes for a presentation and 5 to 10 minutes for a Q&A session, as well as discussion. And title of the today presentation is Introduction to Health Economics and Outcomes Research. And now I would like to introduce our today's speaker, Mr. Olga Pitsillidou. And Olga is working group for co-leader. She is currently an officer in the pharmaceutical care team at the Health Insurance Organization of Cyprus, providing some scientific and administrative support to the Managed Entry Agreement Committee. Currently, Olga's research on the economic implications for ensuring access to medical innovation demonstrates her commitment in advancing health policy and pharmaceutical management. Okay, so Olga, please go ahead. The floor is yours.
And yeah, please again for the participant, please shut your camera and your microphone down, please. Olga, you can share your screen. Apparently everything is okay. So you can put it full screen. So you have 20 minutes, 25 minutes maximum for your presentation.
You can see my full screen?
Yes, perfect.
Great.
Lovely.
So, hello everyone, my name is Olga. As Pavel said, I'm the current co-leader of Work Group 4, which is focusing on the pharmacoeconomic aspect of therapy personalization in biologics in inflammatory conditions. And we will be doing a very short introduction to health economics and outcomes research. So, to begin, what is economics? Here you can see some of the more formal definitions, but essentially economics is the science of how we can decide what to do with our stuff. And by stuff, we refer to our money, time, our vote, and all other options we have in life. So it is the study about the preferences, incentives, and disincentives that are driving our decisions. So while our needs are infinite, our resources are finite and usually constrained. Therefore, we need a way to inform our decisions so as to maximize the potential benefit arising from our choices. What we want to do is to distribute resources effectively and efficiently. And the choices we make about how to spend our limited resources define our future. Therefore, our decisions should be taken in such a way that they will have a positive impact on social welfare. As far as our own lives are concerned, we mostly understand that our decisions on spending of resources need to remain within our budget capacities. Therefore, we implicitly value our utility, the utility we would gain from each option, and we make our choices based on that. A very good example would be spending our monthly amount allocated for groceries on a very nice trip somewhere in Europe. In this case, this is Porto, lovely Porto for those who joined us last year there. So, moving from personal economics to traditional economics, what we do in traditional economics is that we assume that the market is efficient and prices reach an equilibrium through demand and supply forces. What we also assume is that buyers and sellers are in possession of perfect information and thus make rational decisions that maximize their own utility. This is called the theory of rational choice, and it assumes that consumers are rational and make the decisions based on stable preferences, that consumers can objectively anticipate the results of their choices, that they can objectively judge where their best interests lie, and that they have perfect information about the alternatives they have when making a choice and the capacity to evaluate it. These, especially the last one, the having the perfect information and the capacity to evaluate it, is one of the fundamental assumptions of an efficient market. So health economics is a distinct branch of economics. The deviation arises for many reasons, and these reasons have to do with the unique economic characteristics of the healthcare market. To begin with, the fundamental assumption of an efficient market does not apply to healthcare, which is characterized by uncertainty and market failures. So why is that? It's because the ingrained uncertainty in data and the lack of ability to assess any information available by the consumer, combined with the urgent nature of healthcare decisions, distort the demand side of the market. So if you're having a heart attack, you will not be shopping around for the best prices. You will usually go to the first doctor that comes your way. You will also not be really aware of which course of action you should take or which medication regime you should use. Even if all the necessary information is given to you, you're neither trained nor in the position to assess it in order to make a decision. Therefore, the healthcare market is largely supply-driven and prices do not reflect market equilibrium. Further to that, the healthcare market is complicated by the presence of a private or social payer, which manages access for the consumers, patients in this case, and reimbursement for the suppliers, which would be the healthcare providers in the case of healthcare. So what does health economics do? Health economics aim to help assess, inform, and guide decisions of the allocation of the limited and constrained resources. And this is done by navigating around the known market failures and uncertainty. Here, I hope you can see my pointer. You can see a diagram summarizing market failures, which are very prominent in healthcare. So, to better describe health economics, the way health economics is taught nowadays, I find that the best way to do that is through the Williams plumbing diagram, which is a conceptual framework developed by Alan Williams, apparently, to categorize the key areas of health economics. The diagram uses a plumbing metaphor, illustrating the interconnectedness of different topics within the healthcare economics, similar to how pipes would connect different parts of a plumbing system. So you can see, apologies, you can see the 8 areas which are constructed through pipes in the model. The 8 key areas, I will not go through them one by one. But if anyone is interested, it would be a very nice diagram to go through. So the diagram connects these 8 areas. It uses the pipes, as we said, to show the interconnectedness of the different topics. And the arrows show the flow of decisions and economic interactions within the healthcare system. Now, as we mentioned in one of the earlier slides, further to market failures, healthcare has a lot of ingrained uncertainty, especially where data is concerned. So this happens mainly because health data is complex. It's not always available in a workable format. Access to it is governed by strict regulations, and health definitions are not always systematized. Nevertheless, health data is aggregated in registries and studies and can be used to populate models and analysis. So, in short, the way uncertainty around effectiveness of modalities is tackled is by the aggregation of data through epidemiology. The use of robust epidemiological data is the backbone of any economic analysis of HTA. I also added to the slide the saying one of the sayings that's haunted me since my very early steps in the health economics path, which is here. So whenever I'm faced with any piece of information, this saying comes to mind, and I automatically take a step back and look for the data and its trail. And what the message we want to convey through this saying is that no piece of information is credible unless there is good quality data to back it up. Now, going into economic evaluation and health technology assessment. Economic evaluation is a tool which is routinely used by healthcare systems as part of a comprehensive health technology assessment in order to inform reimbursement choices mainly. Generally, health technology assessment, HTA for short, is used in order to determine the value of a modality at different stages in its life cycle. I would like to mention, since we're currently in February 2025, that since January, the European HTA regulation has taken effect, apologies. This directive marks the official initiation of the joint clinical assessment and HTA evaluation eras for the European Union. Now, the joint clinical assessment and joint HTA assessments aim to harmonize clinical evidence evaluations across EU member states. The EU wishes to ensure a consistent and transparent assessment of new medicines and medical technologies throughout the states. In theory, this will reduce duplication of efforts, it will conserve resources and accelerate market access, while also improving efficiency in healthcare decision-making. Now, what the EU hopes to see is an enhanced collaboration between states, reduced costs for manufacturers because of the single submission, more equitable patient access to innovative treatments. But we expect some challenges arising from the alignment of national reimbursement policies with EU-level evaluations. And what we would like to do to prevent the creation of barriers from the implementation of this new regulation is to ensure methodological consistency and balance stakeholder interest across diverse healthcare systems. Now, why is HTA necessary? HTA is necessary since, regardless of the chosen financing method for healthcare, resources are always finite. So no matter if healthcare is paid through a social system or if it's a private or an out-of-pocket system, the money is always short. The result of this constraint is that funding one technology inherently results in not having the necessary resources to fund another. And this is what we define in health economics as opportunity cost. Therefore, we use economic evaluation as the tool to assess which technologies offer the highest return in value or benefit over the others that we will not be able to fund as a result of choosing the first one. Now, value or benefit in health is defined as the health benefits achieved through the resources spent. These resources, as we said in the first slide, can be money, time, vote, infrastructure, while our health benefits are measured as life years saved, cases averted, or any other healthcare metric. Now, opportunity costs are defined as the loss of value or benefit that would result by funding one option relative to funding an alternative one. Put it in more simple words, it's the cost of what we give up when we adopt one option over another. Now, over here, we can see the flower of value as depicted after the proceedings of an eSport task force that set out to identify and define a series of elements that would warrant consideration in value assessment of medical technologies. For people who are not aware, eSport is the official society of health economics and outcomes research professionals. And the reason of this, the reason the task force was assembled and created the flower was because value is very ill-defined, especially in health economics. Now, on the upper right-hand side, you can see the mathematical interpretation of value here. On our lower right-hand side, you can see a comic strip describing opportunity cost. This is a scene many of us have witnessed in our personal life. What the comic strip describes is us being asked to give away an hour of our time in meetings without gaining any utility. And it's the perfect representation of opportunity cost. Now, once we have assessed the value of utility offered from each modality, we can determine the trade-offs that will arise by the decision to fund it or not. Trade-offs take us back to the first slide and our European trip example. In this example, spending all of our monthly budget on a trip to Porto would not allow for enough budget to get groceries for the month. Therefore, in this scenario, while the resources spent are equal for both case A and case B, the utility gained by each of the cases will be the defining factor into informing our decision. Now, would we be willing to trade off the larger utility of a full month of grocery shopping over the utility offered by a European trip? So trade-off is the alternative we give up every time we choose one course of action over the other. And this brings us to what is utility in health and how we measure it. Considering the diverse nature of diseases, it would be very hard to pinpoint a single measurement that would serve all diseases. So a quality-adjusted life years was invented, and it is a number that describes the health state or outcome of a patient ranging from zero, which represents death, to 1 representing full health. Health utilities allow morbidity and mortality improvements to be combined into a single weighted measure of quality-adjusted life year. In general, QALY is the generic measure of disease burden, and it includes both the quality and the quantity of life lived. One QALY equates to 1 year in perfect health. QALYs allow for broad comparisons across different disease areas and different programs. They are calculated by multiplying the time a person stays in each health state by the health utility of that health state. And we sum up the obtained products for all states to achieve the QALY. QALYs are the health outcome preferred by HTA agencies. And this is because they encompass many different aspects of the disease, while at the same time they offer the option of comparing utilities across different health programs. Nevertheless, QALYs can be hard to interpret or validate in real life, and measuring health utilities is not an easy task. Now, the difference in utilities when comparing two alternative courses of action is called delta QALY, and it is schematically represented here. The second measure of population health you will encounter in economic analysis is a DALY. DALYs are disability-adjusted life years, and they are a measure of lost healthy life. It combines the burden of mortality and the burden of morbidity into a single number. Now, the DALY ranges again from 0 to 1, but this time 0 represents full health and 1 represents death. So it is the exact opposite of the QALY, its range. The DALY was first developed for the primary purpose of quantifying the global burden of disease. However, the developers of the DALY explicitly intended that the measure could be used also as a metric for health benefits as a denominator of cost-effectiveness ratios. Now, in present day, the DALY is widely used in economic evaluation of health programs in developing countries. And I would like to briefly go through on how we measure utilities. So health utilities are measured by either direct or indirect methods. Direct measurement methods would be standard gamble and time trade-off methods, which are based in economic utility theory. This roughly translates to a condition where the respondents are asked to consider how much they would be willing to sacrifice to avoid being in a particular health state. However, these methods do not encompass the complex essence of health-related quality of life. Indirect methods are more comprehensive and are basically validated questionnaires where a set of items relating to quality of life is described through level attribution. Questionnaires can be generic or they can be disease specific, and they can be directed to patients, caregivers, or proxies. This gives us a metric which is then used as a utility for each health state. Now, we have briefly elaborated upon economic evaluation, and I would like to go into a bit more detail. Economic evaluation is a decision-making tool. In the Blue Book, the Holy Scripture of Health Economics, it is defined as follows. It is a comparative analysis of alternative courses of actions in terms of both costs and consequences. There are 4 types of economic analysis, which I believe we should not go through in detail now. But regardless of the alternatives, economic analysis is, in essence, a method to compare courses of action and choose one that will increase social welfare. The way the 4 methods differ is in the outcomes they measure. Resources used are always measured in monetary units, but the outcomes are measured in different ways for each method. And this is the main determinants of which analysis will be chosen. Now, when comparing health programs, option A has a cost and an outcome, and so does option B. The difference between costs, that would be the incremental cost, divided by the difference between benefits, the incremental benefit, would provide a ratio known as the incremental cost effectiveness ratio, the ICER. The ICER is the ratio of extra cost per unit of health effect for the more expensive therapy versus the alternative. The ICER is then plotted on what is known as the cost effectiveness plane. In this way, we diagrammatically showcase whether the program considered for funding offers a better value for money than the one it is compared to. Each quadrant represents a different decision to be made. Here we have cost-effective options. Here we have options that dominate the older one. Here we have dominated options, and here we have options which offer less health for less money. Through the plane, we see the willingness to pay threshold, which is defined by each payer, by each healthcare system. This is not a set value. So, in addition to the main cost effectiveness, to the main economic analysis, such as cost effectiveness and cost utility, which we described earlier, we have other methods of economic assessment, such as budget impact analysis and the cost of illness studies. Budget impacts are used to assess whether the adoption of a new health technology is affordable, given the resource and budget constraints of the context. We see an increase in the use of budget impacts and in the value they are coming to have in healthcare systems and health technology assessments. This is happening because no matter how much utility a new program offers, its budgetary impact will be, if its budgetary impact will be catastrophic for the healthcare system, it should not be funded. So no matter how good a product is, if we do not have the money to fund it, we cannot do so. We also have cost of illness studies, which is a way of measuring medical and other costs which result from a specific disease or condition. This is a useful economic evaluation in prioritizing between diseases, but it does not help in getting an efficient healthcare allocation for coverage and reimbursement decisions of a particular intervention. To summarize everything up, and to conclude, health economics is a distinct branch of economics characterized by uncertainty and market failures. In order to counter-effect these and inform healthcare decisions that will increase social welfare, tools like HTA and economic analysis are used. These tools should provide health systems with the data that will inform choices that will allocate limited resources more efficiently, maximize health gains, and minimize opportunity costs. Health systems have a responsibility to ensure that resources are allocated efficiently and provide good value. And it is important that healthcare professionals have an understanding of health economics as the efficient allocator of resources, and thus the sustainability of health systems extends in all directions in healthcare. That would be all.
Thank you, Olga. Excellent.
Thank you. Thank you, Olga, for the excellent presentation. And please turn on your cameras and microphones right now. And now we have a Q&A session. Danny, do we have any questions on chat?
Not on the chat. I have one question, Olga. When it comes to chronic inflammatory diseases, do you think QALYs are more adapted than DALYs or the other way around? We can't hear you.
I'm sorry for that. So I think it depends on the modality you would be investigating and what you would like to see. So as we said, DALY fully encompasses the disability.
Okay.
There are inflammatory conditions where the disability scale, the disability we see is not as much as others. So I would say that depending on what you're investigating and what your end result, what end result you would like to see, you should choose your metric in that sense.
Thank you. Any other question? So please open your camera and ask a question if you want. When it comes to cost, do you account for the environmental impact of producing a molecule, let's say a chemical molecule or biochemical molecule that has an impact on the carbon footprint and also environment? So do we account for that?
If you would be analyzing the cost of producing the modality, yes. Economic analysis is mainly used as a form of informing reimbursement decisions and allocating healthcare resources. So we are seeing a trend of healthcare systems turning green and now accounting for the environmental impact costs. But I do think we are quite far away from fully incorporating it into economic analysis. And in my very humble opinion, we do have a lot of road to cover before we are worried about the environmental impact being the determining factor of reimbursing healthcare choices.
Thank you, Olga. I think unless there is any other questions, so we maybe can move on the next webinar, so we can announce that. Pavel, do you want to introduce the next webinar?
Yeah, sure. Next webinar will be held on 11th of March this year from 5 p.m. to 5:30 p.m. And the speaker will be James Blewett from the University of Manchester, United Kingdom. And the title of the webinar would be Clinical Efficacy versus Effectiveness, Ideal Results versus Real-World Impact. So we would like to invite you all for the next webinar next month. And okay, thank you for attending and participating this event. And
thank you all. And thank you all, and thank you, Pavel, and thank you, Olga, for this excellent webinar series. Wish you a nice day, and hope to see you again next month.
See you the next webinar next month. Bye.
Bye.
Thank you. Bye.